Assalamu alaikum. Today we are discussing a case of a male patient who is 60 years of age, is physically fit and has an ideal weight, has got 2 marriages and is sexually active, and he's very much worried about his erectile dysfunction. And he also has a severe lower urinary tract symptoms with predominantly voiding symptoms. On DRE, he has got benign features of the prostate and serum PSA is 5.1. The ultrasound shows 80 grams of prostate with the median lobe with a post void of 25 out of 50, which is inadequate, and his maximum flow rate is 4 ml per second. So we decided to go for intervention. These are the findings of the cystoscopy. This is the left lateral lobe and the right lateral lobe, and this is the median lobe. All these lobes are completely obstructing the bladder neck. So on cystoscopy findings, you can see this was the left ureteric orifice, the right ureteric orifice, and you can see a paraureteral diverticular formation on both sides, more so on the left side. You can see the mild to moderate trabeculation of the dome of the bladder. Upon general cystoscopy, we can see that there is a lot of inflammation around the bladder, but there are no evidence of any bladder growth. So this shows clear-cut obstruction of the bladder outlet. So we decided to perform transurethral resection. So this is the median lobe here. You saw the bladder neck. So in the transurethral resection, we first resect the median lobe and we make a crater so that the inflow and outflow during the procedure of the fluid is uninterrupted and the vision remains good. The key to successful performance of the transurethral resection is the good visibility. So for that visibility, flattening of the median lobe, making a crater is important. The fluid will go in and will come out efficiently, and hence the vision will be good, and the procedure will then be performed with greater ease. So it will take less time for resection. So this is the routine that I follow. As we saw from the data of the patient, is that he's a very much physically fit patient. He's a younger and is worried for erectile dysfunction. So we will perform a minimal resection here, trying to stay away from the capsule as much as possible, number one. As we know that the nerves for the erectile function are running along the posterior lateral aspect of the prostate, just outside the capsule. So staying away from the capsule with the diathermy, be that cutting or especially the coagulation mode, we can preserve the erectile function of the patient, number one. Number two, you can see the bladder neck fibers. So we will try to preserve as much of the bladder neck fibers as possible so that he doesn't have a retrograde ejaculation as well. As the bladder neck fibers are not contributing towards the obstruction, that's why that will be the second reason not to resect them, and it will also help in some bit of continence of the patient. So preserving bladder neck fibers do have advantages. As it is an educational video, for the better understanding, we will coagulate each and every vessel. Here you can see that there is a spurter. This spurter needs to be coagulated there and then, but we don't usually do the coagulation in such manner in routine procedures. But for beginners, it is advised that such kind of brisk bleeders are coagulated there and then, because if 2 or 3 such brisk bleeders they combine, they can really hamper the vision, and the beginner may get a little anxious, so the procedure will become quite difficult. Here you can see that I'm pushing each and every chip into the bladder. This is also because this is the educational video and we need to see the prostatic cavity so that the beginners and the learners can see the cavity as a whole. This breast bleeder needs to be coagulated there and then. So after flattening the median lobe, we usually go for the lateral lobes. I prefer to resect the left lateral lobe first. There is no scientific reason, but it becomes the personal habit. Some people like to resect the right side and some people would like to resect the left side. However, you can see that resection usually starts at 4 to 5 o'clock position and then is moved towards 3 o'clock position or 2 o'clock position. So we go from below upwards. The advantage of this is that if you start resecting at 1 and 2 o'clock position and come downwards, what will happen that the remaining prostate will fall down upon the verumontanum, and this will make the resection a little difficult because the verumontanum, the area around the verumontanum is the most difficult one to resect for the risk of incontinence. So for a beginner that would be a little bit difficult. So we make a map and we just resect the area. After resecting the median lobe, flattening the median lobe, we resect the left lateral lobe and then completing the resection towards the 1 o'clock position. Then we start resecting the 7 to 9 to 10 o'clock position or even 11 o'clock position. So we resect this area. Now you will see that I'm taking a deeper and larger chips at the beginning, but later in the procedure I'll take shallow chips. We'll show that when we'll discuss that. Here I'm taking deeper and bigger chips, and we are resecting systematically. As I already said that in this patient particularly, the erectile function needs to be considered, number one. Number two, the retrograde ejaculation needs to be considered, and the most important thing is that the patient should have symptomatic relief. So the important thing about transurethral resection of the prostate that one should be clear of is that this is a procedure for symptomatic relief. It is not a radical procedure. So we do not necessarily need to remove the whole prostate. The disadvantages of resecting deep towards and the capsule is that, number one can perforate the capsule and that perforation, if it starts bleeding, it is extremely difficult to control that bleeding, number one. Number two, the fluid can extravasate through that breach in the capsule in the periprostatic area, which may be a nidus for infection. This is number two. And number three, we have seen clinically that patients in whom the prostate is resected up to the level of the capsule, post-operatively they have more burning maturation and they have irritative LUTs for a longer period of time as against those patients in whom the capsule is not exposed. So now you can see that after resecting the left and the right lateral lobe, more of the median lobe has popped up. So now we can easily resect that that portion. The median lobe should not be resected initially in a deep way, because that can lead to the undermining of the bladder neck, and this is the most common mistake which is made by the beginners. They usually start resecting the median lobe. They keep on resecting until by the end of the procedure they come to know that they have undermined the bladder neck. And undermining bladder neck can have so many consequences, especially bladder neck stenosis is one of them. So undermining must be avoided. Now you can see that as we are resecting more and more of the prostate, resecting one area leads to popping up of prostate from another area. So we resected the median lobe, and now we can see that the lateral lobe, left lateral lobe, is popping up again. So when we resect the popped up left lobe, we will see that more of median lobe will just pop up. So we will resect that area too. Now here you can see that the median lobe has popped up again. These are the vessels in the bladder neck. You can see the transverse fibers or the circular fibers in the bladder neck, and we are trying to preserve them. We are resecting deeper and taking deep chips until a point is reached. That point is actually the small black dots. These small black dots are actually a sign that we are getting near to the prostatic capsule. Here we are resecting the anterior lobe, as in 90% of the cases there is no need to resect the anterior lobe, because anterior lobe does not contribute to the obstructive element of the prostate. However, if it drops down, it is good to resect only the area which has dropped down, because if you resect it deep towards the capsule, one may open the prostatic venous sinuses, and then the consequences are again very dire. So talking of the small black dots, they say that these are calcified. Micro calcification have occurred in the prostatic glands because of chronic inflammation between the adenoma of the prostate and the true capsule. So they are a sign that the true capsule may be near. So after seeing those black dots, you can see them around here. There are small dots, black dots, you can see. So after seeing the black dots, one must be careful taking deep chips, because taking a deeper chip may lead to contraction of the fibers, the muscle fibers in the prostatic capsule, because of the activation by the diathermy. They contract, and the capsule comes onto the resecting loop rather than resecting loop going into the capsule. So this may lead to breaching of the capsule. So one must be really careful. And the second sign of that we are near to the capsule, the true capsule, that is are the bigger vessels and brisk vessels and arterial vessels. So because the arterial blood supply usually runs in the space between the adenoma and the true capsule. So seeing those brisk vessels, arterial beads, should also make the surgeon alert about the nearness to the capsule. In this particular case, once again, I have to remind you That is a younger patient who is sexually active. So our intention is to make him symptom free and at the same time preserve his erectile function as well as prevent the retrograde ejaculation. So we will not be resecting a lot of prostate here. However, it is important here to mention that if he was an older patient with an age of 70, 75, not sexually active, we would have resected more prostate. But here we are only resecting the areas so that he should become asymptomatic. Here again, you can see that resecting the lateral lobe has made the anterior lobe pop up and drop down into the cavity, so we have resected more of the prostate which has dropped down. Resecting the lateral lobe leads to popping up of the median or rather the posterior lobe of the bladder. You can see the verumontanum. At no point during the procedure one should come distal to the verumontanum. Here you can see that I am taking superficial chips and I am pushing, coming towards the urethra and then pushing the prostatic tissue into the prostatic cavity and then resecting in order to, number one, prevent incontinence of urine, and number two, prevent bulbar urethral stricture, because the more distal you come with diathermy, the more are the chances of making post-operative bulbar urethral strictures. At no point during the procedure one must use the diathermy if verumontanum is in the vision. If the verumontanum is seen and is in the vision and you are using diathermy, it means that the heat of the diathermy or electrocautery may reach the urethra distally. So strictures of bulbar urethra are more common in such conditions. Here you can see I am coming back towards the verumontanum, taking the flaps of the prostatic tissue into the prostatic cavity and then using the diathermy. We are coagulating thoroughly here just for the educational purposes so that everything is visible to the students. Otherwise, there is no need to coagulate these small bleeders during the procedure, because the more you coagulate, the more time it takes. The indications for transurethral resection of the prostate. Prostate which is enlarged, giving moderate to severe lower urinary tract symptoms according to International Prostate Symptom Scoring, with a bothersome score of 4 to 5. Failure of medical therapy. Post-void residual volume is a good indicator of bladder function and outlet obstruction. Urine flow rate of less than 16 ml per second without alpha blocker. Presence of a median lobe in the prostate. Then, of course, the most common indication for resection of the prostate is refractory urinary retention, number 1. Number 2, recurrent urinary retraction, recurrent urinary tract infections. The absolute indication is bladder outlet obstruction leading to back pressure azotemia. formation of a bladder stone, formation of bladder diverticulum, and of course, according to some other complications like direct inguinal hernia, hemorrhoids, or worsening of hernia already present like umbilical or perumbilical hernias, or worsening of indirect inguinal hernias. So all these are indications that the bladder neck is obstructed or bladder outlet is obstructed. So we are resecting the area near the verumontanum in order to reduce the obstruction, but at the same time not coming distal to the verumontanum to avoid incontinence. So a good channel is made here. Hopefully this will make the patient symptomatically better and also not compromise his erectile function and will not cause retrograde ejaculation. Plus we will have a histopathology as well, although his serum PSA is 5.1. The most tricky is the area near the verumontanum. Completeness of the procedure can only be assessed after emptying the bladder 2 or 3 times after the procedure. The most common mistake by the beginner is that continuous resection is performed and the bladder is filled and the prostatic cavity is stretched because of the inflow of the fluid, and the beginner thinks that a good channel is made. However, when the bladder is emptied 2 or 3 times, so the pressure in the bladder is reduced and more of the prostate pops up, which may lead to smaller degree of obstruction, so lesser relief in the symptoms. So the lesson here for the beginner is that completion can only be decided if the bladder is emptied 2 or 3 times, and that happens automatically when the chips in the bladder are evacuated by Helix evacuator. Then you will see that more of median lobe, more of lateral lobes have popped up again. So here, a good symptomatically relieved procedure is performed. The channel is made, as I mentioned earlier, that if the particulars of the patient were not the ones that we discussed, if he was a patient who was not sexually active and his age was 65 plus, 70 plus, when the only important thing would have been avoiding, I would have flattened the bladder neck and I would have resected more of the prostate. But here I have made only a channel wide enough which will give the patient good symptomatic relief. Hopefully in the future I will share another video where a more resection is performed in the prostate, and I will show that and share on my YouTube channel as well. Here you can see that small black dots are seen, which show that resection is almost complete for this patient. this particular patient. There is no need to coagulate the whole cavity. The more you coagulate, the more charring is produced, and more charring leads to more chances of infection, number one. Number two, use of or excessive use of diathermy, I would say, can lead to bladder neck stenosis in the form of fibrosis. So only the active bleeders need to be coagulated. Care must be taken coagulating the flaps of the prostate near the veromontanum. As I already discussed previously, this may lead to, number one, incontinence, number two, urethral stricture formation. And there is usually, if no active bleeder is there, there is no need to coagulate this area, as a 22 FR 3-way Foley's catheter will snugly fit into this portion of urethra, and the small bleeders, if any, will be stopped by tamponade effect anyways. So there is no need to take risk with incontinence and stricture. I'm talking about these areas. These areas, if left alone, will be better, but since this is educational video and we need to have a clear vision, that's why I coagulated them. Thank you very much. I hope you enjoyed the procedure. Next time I will share another prostate which is more completely resected. Thank you very much for watching.